after all this time. Mixed methods to study substance abuse and health outcomes associated with use in homelessness and HIV and overdose. He's also a professor at Drexel, so thought we'd add that piece in too. And so he's director of Drexel's Medical Cannabis Research Center and is leading a patient registry study of medical cannabis patients in Pennsylvania to determine the impact of medical cannabis on qualifying medical conditions such as chronic pain and PTSD and anxiety. He's co-leading 2 NIH-funded studies, a 5-year renewal study of cannabis use among young adults in Los Angeles, and a 5-year study to deploy a mobile phone application, Unity Philly, to deliver naloxone to overdose events in real time across Philadelphia. He teaches a variety of graduate courses, proposal design, qualitative methods, and substance use, has a history at Drexel. He's a recovering associate dean in research. He says he's fully recovered. You never know. And so, yeah, and it's great to have him here. It's been great talking with him, and I'm going to turn it over to you.
Thank you, Deborah. No, I think I have to, there we go. Well, good afternoon. Thank you for that introduction. And it's great to be here at Washington University and to participate in this series talking public health. Before I begin, I think it's difficult to give a talk in public health in these times, given everything that's going on that we're all living through, whether you're in public health or academia, doing NIH-funded research, or just being a human being. But I thought I would just mention that at the outset. I won't be sort of engaging in those issues directly during this talk, but we could certainly talk about those in the Q&A period. So my title is New Directions in Cannabis and Overdose Prevention Research. So you can kind of get 2 talks in one here. I'm first going to go through I couldn't choose which topic I want to talk about more, so I'm going to give you a little bit of both. So I'm going to start off on this, what I'm calling the controlled use of cannabis R01. And the objectives of this presentation is to describe the background and rationale for the study on controlled use, to report some preliminary data supporting the study, to describe what we're calling the cannabis rules of a controlled use scale, or CROCUS, and then to provide an overview of some key components of this study on controlled use. So before I kind of get into the actual heart of the matter, I'm going to give you a brief background on the study, which is actually the second renewal of an R01 that first began in 2013, focusing on medical cannabis. So as part of this presentation, I'm actually going to be giving you some preliminary data from these 2 earlier studies, but I thought I would just mention that there's a through line that goes all the way back to when I first began doing drug research in New York at a research institute called NDRI. And so in the course of those projects, I learned a lot. I was doing research on people who inject drugs, learned about this emerging phenomenon called ketamine injection. So that converted into a first study on called ketamine injection and HIV risk. That study provided some pilot data for a larger R01 on a multi-site study focused on ketamine in New York and Los Angeles. In the course of that study, during that period of time, there were a lot of young people who were misusing prescription drugs. That seeded a study focused on prescription drug misuse among young people in New York and LA. And that study in Los Angeles learned about young people who had recommendations for medical cannabis who were performing better than people who did not have recommendations. That led to the first R01. So just kind of want to point out how my research is all sort of linked up in one shape or form, and I can find a line all the way back to the start of my research career back in 1999. And I should also point out that all this research focuses on young adults, like 18 to 26-year-olds, because young adults use substances at the highest rates and are often at the front end of emerging drug trends. So I'm going to start with a little background on the legality of cannabis. And so this trend towards legalization started in 1996 in California. The first 2 states to legalize cannabis for adult use was in 2012 in Washington State and Colorado. And now most states either have legalized cannabis for medical use or adult use including Missouri, which is a real kind of surprising transition that's happened over a 20-year period or so. So not too surprising, as cannabis has become more accessible and available through legalization, the prevalence of cannabis use has doubled across all age groups from about 7.5% in 2013 to 15% in 2022. Rates of use are highest among 18 to 30-year-olds. About 25% have used cannabis in the last 30 days. Now, during this period of increasing access and availability, the potency of cannabis flower has also increased pretty dramatically. As people like to say, it's not your father's weed or your grandfather's weed. You can see the potency has really gone up from the early 70s when it was kind of below 2% all the way up, pushing now to like 20%. So that's a pretty notable changes. Furthermore, as cannabis has become more available in dispensaries through adult use or medical use, the variety of cannabis products has really increased pretty dramatically. Some of you may know this, given that cannabis is illegal for adult use here in Missouri. So it comes in forms of like oils and vaporizers and topicals. And the important point here is that the potency is now often above 50% THC, sometimes 80, 90%. So we have this situation where cannabis is more widely available, potencies have gone up. So an outcome that one might wonder is like, okay, given this increasing potency availability, what about problematic cannabis use? So it turns out between 2017 and 2020, the prevalence among people who have used cannabis in the last year who qualify for cannabis use disorder has gone up pretty notably. Severe has gone up over 3.5%, moderate up 5%, mild up 4.5%. Now, so those are all concerning trends. And call me a glass half full kind of guy, but where my interest actually landed is down here. And the fact that even though cannabis is widely available, most people are not developing a cannabis use disorder. And so this kind of harkens back to some of the earlier research I was talking about. People who inject drugs, spend time interviewing them who are not contracting HIV, who are not contracting HCV, who are not having an overdose. So what are those people doing right that might be protecting them from some of these negative health outcomes? So looking at my own data on this study of young adults, who we collected 8 waves of data over an 8-year period, similarly found that surprisingly, as the same time periods as cannabis became legalized, the proportion who had cannabis use disorder, according to our surveys, went down, which kind of goes against the trends that I just presented. But still about 2/3 did not have a cannabis use disorder. So we're in the position of trying to come up with an idea for a second renewal for this NIH study. And so it occurred to us that maybe we should be focusing on these folks who seem to be functioning fairly well, despite kind of, frequent cannabis use. So, in this era of increasing access to cannabis, why not study regular or frequent users who don't seem to develop cannabis use disorder and understand how they control their cannabis use? So that became sort of the premise for this new study. So the theoretical perspective that we leaned on was one of my favorites. It's a book by the physician Norman Zinberg wrote in the 80s called Drug Set and Setting, the basis for controlled intoxicant use. And this book is kind of known for understanding how people who were opioid users at that time period did not go on to become heroin dependent. So we have this potent substance heroin, yet people somehow figure out a way of not becoming dependent. And so, at the time, interestingly, this book also included people who use cannabis, but that wasn't really they found that there wasn't really a problem around developing dependence in the early 80s on cannabis because the potencies were a bit lower. So our idea was, let's apply this theory that's been around for a while to the study of cannabis use. But the central part of this theory, and which I like because I'm a sociologist, is that the control comes from the setting. That in the setting, there are these different rules and rituals that kind of dictate when people use substances. And to kind of borrow from the alcohol realm, which may be a little more familiar, there's this concept of a cocktail hour, where it's sort of a ritualized time of day when someone may have drinks with certain glasses or people or accoutrements, and that's when you consume alcohol. You don't do it at other times. So that's like a ritual that kind of controls when people use alcohol. There are other rules that people might use, like in addition to rituals, which are these kind of more practices, there are rules as to when, where, or how much to use. Like you don't drink before noon, or that you may only have never more than 2 drinks. But in the cannabis realm, because of the stigmatization and criminalization, a lot of these rules around controlling cannabis use aren't that well identified, or never really been passed down from generation to generation like they might for alcohol, for instance. So that was kind of the issue, that these rules around controlled use of cannabis are fairly unknown. So the conceptual framework that we're applying in this study is Zinberg's framework, where we're going to be looking at kind of assuming that the setting is driving these rules of controlled use. In addition to the set, we kind of acknowledge that your psychological disposition is likely also to have some impact on the rules and rituals, and that these rules and rituals can help to sort people into either uncontrolled users or controlled users of cannabis. And that these rules and rituals will then have outcomes that impact key arenas such as the substance use, as well as psychosocial functioning. So now I'm going to show you some pilot data from the earlier R1s that I presented last summer at a meeting on the College of Problems of Drug Dependence. We're also developing this data into a manuscript for publication that we're close to having ready to submit. So the data is based on this study I mentioned earlier. We recruited 18 to 26-year-olds who used cannabis in the past 90 days in Los Angeles. We surveyed them over an 8-year period, and I'm going to present kind of data from just 2 periods, 2014 to 2015, when it was a medical-only policy, and then the last wave in 22 to 2023, when it was adult use in Los Angeles. We applied this theory and developed a latent class analysis, and we used 5 survey questions that we put in the original survey that we had never intended to use in a study around controlled use, but based on the literature, felt like it kind of represented different types of rules. So one rule is not being under the influence of cannabis while gathering with family. Another is not being under the influence while performing schoolwork or related duties, not being under the influence while driving. So those are kind of three rules around time and place of use. Another is using cannabis at specific times. So you're not using it morning, afternoon, evening. It might be only in the evening or in the morning. And that you're able to kind of stop using cannabis for at least 1 week in the past 12 months. Kind of the idea of a tolerance break, that you're able to kind of cessate if you need to. So I'm showing you now the kind of the first results of the latent class analysis, and you can see we have the majority of our sample this period actually fell into the uncontrolled group, about 60% in the uncontrolled group, 40% in the controlled group. But we have the blue represents the rules among the controlled, the orange, the uncontrolled. And you can see we have some pretty good separation between the two groups in the first three. Not using while under the influence of with family, school work, driving, a little less separation for stopping use, a little more separation for specific times. Now, this is 8 years later. Still, the sample shook out into similar groups, about 40 and 60% split, but we see a lot more separation on the first three. We see if you look at the uncontrolled first, the orange, you notice that it's fairly consistent compared to the first wave. But the control, the blue, we see a lot more separation in the areas of particularly not using cannabis while going to school or work or driving under the influence. So this is kind of the basic, creating these two groups and showing that there's some kind of separation between the two. So in terms of outcomes, kind of, you remember the model that I showed earlier, one of the areas of outcomes were cannabis use. So here's 4 different types of outcomes. One is amount used in terms of grams, days in the past 90, hits per day. We didn't have the CUD measure in all waves, but instead of the CUD, we have something called the severity of dependence scale. So if you look at these two columns, across the board, the group that we're calling controlled users use less cannabis than the uncontrolled, except for the last wave, the SDS, there was no statistically significant difference. Another thing to point out, if you kind of look at the second line here, you can see that the uncontrolled users at wave 1 and wave 8 are still using around 80 days out of 90. So pretty consistent level of use across the entire study period. But the controlled group dropped from around 50 to around 35. So pretty notable drop in use. And you might attribute that to this increasing of application of rules. That's sort of a little bit our hypothesis. So overall, the greater probability of rules among controlled use is associated with less cannabis use. And these findings paved the way for the development of our second renewal. So this was kind of the core of our justification to submit a new study focused on controlled use of cannabis. So I'm just going to show you the aims and kind of just give you a little review about what we're doing. So the first aim is to develop this new scale that I've mentioned called the Cannabis Rules of Controlled Use to assess the rules of a controlled use during subsequent ecological momentary assessment study. And we've been working on that. We've been pilot testing it. Presently, we have probably around 40 items right now. And it may be a little hard to see these items, but we included some of the items from the initial pilot study. So we have some items focused on driving and kind of using while in school or work, but then other items having to do with using before gathering with children or going out in public or doing outdoor activities. So the idea is to try to really articulate where are people applying rules? What kind of context is someone applying rules to attenuate their use? The second aim then is to determine cannabis use practices and psychosocial functioning. Those were the two key outcomes I mentioned before. Among these two groups using this measure in contrasting policy environments. And the third will involve a longitudinal component. So we'll again be looking at these outcomes using the crocus and doing some more EMA as well as qualitative interviews. Now, I mentioned sampling two different policy environments. So where one of the innovations for the study was to continue engaging this longitudinal cohort in Los Angeles, which started out 18 to 26, now is 23 to 37. So they've aged a bit during this period, as well as I have running another study of medical cannabis patients in Pennsylvania. And so we're going to kind of pull age folks of these same ages from these two different studies and be able to compare how do these rules play out in different policy environments. Some places where you can use cannabis as for adult use, and in other cases where it's for medical only. So if you haven't kind of caught on to the central hypothesis by now, it's that persons who kind of exhibit greater control over their cannabis use via these rules and rituals will be report lower cannabis use and better psychosocial functioning compared to the people who aren't able to apply those rules. So just to summarize, so I've kind of shown you that, over this period of legalization, the access, amount, potencies of cannabis has increased. However, research on using cannabis in a controlled manner has been relatively uncharted territory, largely because of criminalization and stigma around cannabis use. We believe that advancing this kind of this framework will really uncover fill gaps in research and practical knowledge, given how, because of cannabis has been stigmatized and criminalized over this period. The long-term goal is that if we can kind of really understand these rules for controlled use, it could open up opportunities for developing new models around controlled use that could be applied in clinical and community settings that could ultimately reduce frequency, intensity of cannabis use and improving overall public health. So that's my first presentation. I'll move on to my second one. Like I said, couldn't choose between the two. So the second one is I'm going to talk about what I'm calling the opioid overdose prevention R1. So similar, you see a similar structure here as for the first presentation. So I'm going to also give you kind of the background and rationale for the study, describe what we're calling the Unity Philly Overdose Prevention App, report some preliminary findings from the pilot study where we tested out this. We call that version Unity Philly 1.0 because it's the first study, and then provide an overview of the Unity Philly 2.0 study, which is an R1 that's in progress. So you're probably all well familiar with this kind of ongoing overdose crisis that's kind of hitting major cities, communities across the United States. It's described as kind of occurring in 4 phases. So the first phase is kind of the overdose attributed to misuse of prescription opioids. And this is kind of when I first started some of my research on people who inject drugs. You can see overdose rates were fairly low. It was more the concern was on HIV and HCV. The next wave was kind of a transition towards overdose due to heroin, then to fentanyl. And finally, the wave that we're in right now has been this wave that's a combination of fentanyl and other adulterants, often stimulants. So someone thinks that they're using cocaine or some stimulant, but it's actually mixed with fentanyl, and the person overdoses. So we're about 10 years into the third wave and about 8 years into the second wave. You might have also heard that the death due to overdose has actually peaked a year or two ago. In 2023, over 100,000 people died of a drug overdose in the US, which is a 4% decline compared to 2022. There's some speculation that this is partially due to, increases that happened during COVID. However, the decline in overdose deaths is you can see mainly among white non-Hispanics. So we see increases in Black non-Hispanic, Hispanics, Native Hawaiians, and other Pacific Islanders. So by no means should there be any kind of lowering our guard in terms of viewing this as an important problem. Now, there's been some thinking about why has overdose deaths declined. As I mentioned before, some of it may have due to just the circumstances during the COVID epidemic that kind of really ramped up problems that resulted in overdose. But other things such as greater availability of opioid use disorder medications such as buprenorphine, methadone. In some places, the supply of fentanyl has gone down. The next two bullets are kind of crucial to what I'm going to talk about next. Is there's this greater access to overdose reversing drug Narcan, which is now available over the counter, and that crucially, bystanders are often willing to give Narcan to overdose victims, which are often strangers. So that last part is key. So transitioning a little more to this study. So you may know that Philadelphia has one of the highest overdose rates of any large U.S. city. And the overdose crisis has been predominantly concentrated in the Kensington neighborhood of Philadelphia. In fact, the problem in Kensington is so acute that the director of the National Institute on Drug Abuse, Nora Volkov, visited Kensington herself a few years ago. And so Philadelphia trends have kind of mirrored the national trends a little bit. In 2023, over 1,300 people died of a drug overdose in Philadelphia, which is actually a 7% drop from 2022. So there's also a decline happening in Philadelphia. So how does this R1 fit in? So I did have another study focused on overdose prevention that I led based in Los Angeles, running from 2019 to 2009 to 2012. We did sort of a parallel study in Philadelphia. That data formed the basis for the first study, the R34, that I'm going to talk a little bit more about. And then that study I'll give you is kind of what is fed into the current R1 study. And I should point out that the key collaborator that I partnered with for the R34, his name is David Schwartz. He's a professor of information systems at Bar-Ilan University in Israel. So the two of us teamed up to conceive this study. But before I get into some of the details, I have to credit David with the premise of this study. And it came from a strange place. So he told me that he read an interview with the late Paul Farmer that was in Time magazine back in 2013. And the last two lines, which I can't read too very well here, he says, so there's this Q&A with Paul Farmer, and he says, "You miraculously saved a man who was about to die from an asthma attack. What did you take away from that story?" I'd been there in his village for a community meeting, and the only thing I had in my pocket was my own inhaler. If you're having an asthma attack and you can get albuterol, it looks like a miracle. The next day he came to see me and brought me a rooster, and he preys on me. You like that when you're a doctor. And then the person followed, "Well, who doesn't want a rooster?" I was thinking more of the praise. And then you realize it would be better to build a system that protects people from that kind of risk so they don't need a miracle. So the two things here is the reason that this person survived was not necessarily that Paul Farmer was a doctor, but because he had an inhaler on him and was willing to share that with the person who was having an asthma attack. And that kind of point of building a system that protects people from that kind of risk. So that was kind of the translation. We were interested in building a system comprised of everyday people, not necessarily doctors or specialists, to protect others from overdose by sharing Narcan via a new technology. So here I'm going to show you a little bit about, give you a little background on the first study, the Unity Philly 1.0, which ran from 2017 to 2021. So we developed this app with a company called NowForce. We recruited 112 study participants in this Kensington neighborhood that I mentioned earlier, trained them in overdose prevention, including the use of Narcan, downloaded the Uniphilly app onto their phone, which contains a signaler and responder mode. So this graphic here is displaying the signaler one first. So the person has the app on their phone, they see an overdose, they pull out their phone, they click signal and alert, and the signal goes out to people in the neighborhood. This one here, this interface, this is the person who's the responder. So they receive the alert, they indicate that they may be available, they see where the overdose is, they indicate that they're available. Then the person who's the signaler here see that someone's on the way. They get a map, they can chat, they can communicate with the person. So that's the basic concept. So you have in a densely populated area, people with these apps on their phone, they see an overdose, they signal an alert, and then someone who's nearby can show up and deliver the Narcan. So the central premise of this study is like, why would you, I should say another feature of the app is it does automatically contact 911, so the person is able to speak with a emergency operator. So the whole premise here is that minutes matter in an overdose. So if there's someone who is just a few blocks away that can deliver the Narcan quicker than EMS, it could be the difference between life and death or more extreme kind of consequences from the overdose. And in this example here, the person who is having the overdose is down here in the red circle. You can see there's 3 people who have the app on them. This person here is not able to, doesn't respond, but there are 2 people just a few blocks away that respond and are able to show up. And you can see this is the pathway that they took to this overdose event. So that's the basic concept. People who are nearby that are willing to help, that have Narcan, can show up in a matter of minutes rather than waiting for the 10, 15, 20 minutes that EMS might take. So here's some data from the original study. So in a 1-year period, which how long we actually ran the trial, from March 2019 to February 2020, we had a total of 202 alerts. There were a bunch of false alarms, but this is only the alerts that we believe were not false alarm. So in about a third of the cases, there was no naloxone given. So in that case, again, we're just hopefully relying on the person used. They spoke to 911 and someone showed up who wasn't one of our community volunteers. But in a third of the cases, at least one dose of Narcan was given by a study volunteer. So keep an eye on that 74 number there. Among those 74 cases where someone from the study gave a dose of naloxone, 96% of the time there was a successful reversal. There was 1 on-scene death reported, and then 2 outcomes were unclear. So looking at those 74 for one more line here, this is the crucial line. So the first line here is someone who had the app, they signaled an alert, they were the one who gave the first dose of Narcan. So that was the case in 70% of the time. However, the next line, this is what the study was envisioned to do. So in about a third of the cases, 22 times, the person signaled an alert, someone in the community picked up the alert, came to the setting, and deliver the first dose of Narcan. So that was kind of what we were trying to do. So we had it happen 22 times, so about 2 times every month over the course of a year. So this was the big kind of finding that showed us that there's there's feasibility, that this system can work. So this was the basis for then our Unity Philly 2.0. 3 aims. The first aim is to redevelop Unity Philly to ensure ease of use. And a key part of this is to develop a remote onboarding process for study participants and volunteers. So for the earlier study, everything was done face-to-face. I was involved in a lot of the recruitment, but for this study, we're planning to recruit 450 people, so we need to have more of an automated process. The aim 2, we want to assess the effectiveness, the differences in the effectiveness of Unity Philly across varied urban environments and participant profiles during a 12-month trial. So the first study, we did 112. Here we want to increase it to 450, not just one neighborhood, but at least 3 neighborhoods, get a variety of people who might be at risk for an overdose. Of course, people who inject drugs, people who are in recovery, people who might be taking opioids for pain. So that's the kind of the core of the study is aim 2. But then aim 3, we want to see if we can build and study a sustainable environment for Unity Philly to expand citywide. So here we're hoping to disseminate Unity Philly to up to 3,000 volunteers. So to really kind of scale it up to kind of citywide use and effectiveness. So the first part, which we're working on now, and it's turned out to be a lot more complicated than I envisioned when we were writing the proposal, is this remote onboarding process. So it's going to have these components where we first have to screen the person for eligibility, consent them to be part of the study, record a background survey, do some training. We've been developing 4 videos specifically for this project. It's been really fun and exciting to do, as well as choose the method for them receiving the Narcan. Are they going to get it from a project staff, mailed to them, and then finally downloading the Unity Philly app onto their phone. So this is all going to be done for the 450, and then some of these steps will be done for the 3000. We won't be doing a robust survey like this for the 3000, but probably at least the training and the choosing of the methods of receiving Narcan. So for AIMS 2 and 3, we applied the REAIM framework to look at our outcomes. So that the concept of reach, effectiveness, adoption, implementation, and maintenance. So some of our key outcomes in terms of reach: does the reach of the Unity Philly app differ by race, ethnicity, and gender? If yes, why? So trying to understand what are some of the factors, the determinants to figure out who actually uses the app. What factors determine successful reversal of the overdose? Some effectiveness. Adoption. What combination of factors impact willingness to join Unity Philly? How do different participant profiles predict willingness to join? Implementation. What density of the Unity Philly network is necessary to maximize response to signal events in a neighborhood? I should say for the earlier study, we had just often a handful of individuals within the neighborhood around, and that seemed to be enough to be effective. But we want to kind of understand really what's the density needed for this to be effective. And then lastly, what factors determine sustained participation in Unity Philly over time? You can imagine there could be a lot of burnout, or that could happen. Someone who's doing this consistently, they're just a volunteer. But what are some of the factors that might contribute to someone sticking with this over time? So we have more outcomes, but those are just a sampling of the key outcomes. So to summarize here, as I pointed out at the start, fatal overdose remains a significant national public health problem. Fortunately, naloxone is increasingly available as a tool to combat overdose, and that bystanders are willing to respond to drug overdoses. Through our earlier work, we've shown that the Unity Philly app can increase the availability and speed of the delivery of naloxone during an overdose event, which we will expand during this R1. So the long-term goal of the study is that if we can successfully implement this in a citywide manner, we can lay the groundwork for increasing scalability and broader national uptake in other cities, other communities. So Philadelphia is really the test case to see, can we do this on a broader scale than in the first study. So just to kind of bring it back to the title, I was a little mixed on the title. I created it before I came up with the presentations, but I've just finished up a class teaching doctoral students on proposal development. This is kind of a little teachy kind of thing, but what are some of the inspirations for new direction, fill in the blank research? So I think kind of what I've shown here, certainly addressing emerging public health issues can be an inspiration for coming up with new directions. It's like kind of a theme throughout this presentation is the importance of pilot data. They're core to kind of robust studies, particularly mixed method studies. That's kind of qualitative research is actually my primary background, and a lot of these ideas for these studies and kind of talking with people really is what inspires this research. Multi-site projects. So if you're in different cities, different communities, you can be inspired to kind of ask new research questions. Applying novel technologies. So in this case, coming up with an app, this is a really exciting kind of approach to this problem of overdose prevention. Interdisciplinary collaboration. So the collaboration on the Unity Philly, this came from a business professor who was in information science. I think this would be considered public health plus in your dean's new concept. So this was kind of core, kind of two out of the blue kind of two people. He has no background in overdose prevention. I don't really have the technological expertise. We came together and kind of created this project. Diverse staff. I was talking to some of a few doctoral students earlier. So having staff, diverse backgrounds, diverse experiences can always kind of provide new ideas for research studies if you listen to them. Partnerships with community-based organizations. So I didn't talk about that as much, but for the Unity Philly study, we partnered a lot with different groups. We will continue to do that. That can animate the research. And then lastly, thinking about the positive impact on the population study. So one of the really rewarding things about this Unity Philly study in particular is just seeing that this, 22 cases, there was naloxone that was delivered to an event that might not have otherwise been made possible. So I think those kinds of impacts and success can really kind of inspire you for future studies. And lastly, just like to acknowledge my NIDA for grant support on these two projects, and also just a few of the key collaborators for the controlled use study. It's now MPI, Dr. Carolyn Wong in Los Angeles, and other collaborators listed there. And then the Unity Philly R01, my collaborator MPI, David Schwartz at Bar-A-Lon. So thank you. So you got 2 and 1. And 39 minutes and 56 seconds. I think, Deborah, did I make it under the 40 minutes? Okay.
Thank you for that talk. That was really interesting. I had a question for you about the first project.
Sure.
I wondered if there are any similarities in trends post-COVID with cannabis use, like there were with alcohol use, and if that impacted your cohort pre and post 2020.
Yes. So, one thing that another piece of this study is that we have this incredible qualitative data set where we have about 40 or so participants who we have for each of them, about 6 qualitative interviews going over an 8-year period. And so I've been digging into some of those interviews, and inevitably COVID resulted in more use, people were around more. So generally, almost all of the young adults that I looked at, they lost their job during COVID. So their financial situation got rocky, their use went up, both often of cannabis, but other substances, alcohol, having to really be creative to find ways to earn income. Suddenly they were working at X, now they're selling LSD as a way to, make some additional income. So I think that's so we have that in our data, both quantitatively and qualitative, sort of what happened during COVID, and now we're in the post-COVID period. So we'll see if, things start to settle out more so.
That's interesting. I didn't know about if the trends match, but it makes sense.
Yeah.
Thank you.
Steve, thanks for being here. Great work. There's so much in public health. We think of doing prevention now, and 20 years from now, we save some life, but we don't know who and when. But yours is like immediate. So it must be gratifying especially that second study, to see immediate results. I was curious, actually I had several questions, but I think the one I'll ask you is, I was curious in the overdose, when essentially you save a life, when people get the naloxone and they live, what happens to them after? Are they in some service system? It seems like an important thing is you've got a life saved, but then they're living in difficult circumstances.
So it's challenging to get the data on that, right? So the person who saved the person is in the study, but the person who overdosed is not. So we have to kind of rely on their reporting of what they observed at the scene. So we asked them, did the person survive or not? Did 911 show up or not? So I should just mention, in all cases, the volunteers showed up prior to EMS. Did the person, go to the hospital? Did the person relapse? So the data is pretty limited to right within the initial, 60 minutes after the overdose, unfortunately. But the best case scenario is if they do, EMS shows up and then they go to at least the hospital, and if they're able to sort of at least be under observation for a period of time. but many times they don't want to do that. They just kind of want to recover and then kind of be on their way. But that would be another study to somehow track the victims and to see what happens to them after they recover.
It would be a really, obviously, the whole consent and
Right.
confidentiality takes on a different slant on that, but it seems like that's, it's sort of like with cancer screening or any other, you detect something, but then the important part is what happens after that. And you save the life and want to make sure that life is truly safe.
But to your kind of initial observation, as we were talking about during our earlier meeting, my earlier work was focused on HIV and among injection drug users. And I remember distinctly going to a American Public Health Association meeting. I think it was in Boston sometime in the 90s. And there was this community-based group from Chicago called Chicago Recovery Alliance. And they introduced to me for the first time this naloxone reversal. And I was just so taken by that. And so I was kind of, because as you say, the impact is so immediate, that I was really drawn to that as a kind of an area of study.
Also, by the way, you were talking about implementation science this morning, you're doing it.
Good.
You're further down the line that morning. Good job.
And as I said, I'm a sociologist. I don't know all these things. Good to get in.
Sorry.
I have a question kind of on the other end of if there's an adverse outcome. So if the individual overdose dies, and thinking about how we're such a litigious society here, everyone likes to sue everyone for everything. Could that potentially be a deterrent for the bystander to respond, or are you concerned about that at all, or
Sure.
or things?
So fortunately in Pennsylvania, they have what's called Good Samaritan laws. So if someone, in good faith responds to someone who's in overdosing, administers Narcan, then they're in theory at no fault. So that's kind of that. But in reality, there's other things can happen. This study, we have a data safety and monitoring board. So we have a group that we meet with, who reviews our protocols, and we have to be ready to report out any adverse events to that group, to our IRB, to the NIH. So and you can imagine with this kind of highly vulnerable population, there's going to be all sorts of adverse events that may have nothing to do with the study. But so we still have to kind of track those to the best of our ability and see if they're somehow linked to the intervention.
Hi, thank you so much. I'm curious if you're working with any organizations like Never Use Alone who kind of have this geolocating in advance and then could potentially like ping your app to say there's someone here who needs response. Are there any?
Yeah, so we've had some connections and conversations with those groups. The big thing that something we run into, and they're kind of more of a harm reduction group, is that so we have to by consenting to be part of the study, you have to be willing to call 911. So that can be a barrier for a lot of folks because the using alone, they kind of want to keep it out, sometimes outside the realm of EMS for understandable reasons, for police showing up. So at this point, it's a little bit of a tricky integration because they might be, the folks who are using that service may not want to have to be having involved in calling 911. But we have thought about building into the functionality of our app some kind of feature where someone is using alone and that the timer is set, and if they don't, and the alarm goes off, and if they don't turn off the alarm, then it automatically sends off an alert to the nearby community. So we haven't quite figured that out yet, but that's something on our radar because, as you say, using alone is very common and is kind of a primary risk for overdose. Yeah.
Just to keep you on your toes and go back to the cannabis study.
Okay, thank you.
Could you talk a little bit about your recruitment, your kind of inclusion criteria? I am curious about how the cannabis, you said problems or use actually kind of went down over time. And I guess I'm wondering about other mental health problems, if you asked about them, or their substance use behaviors and how that might have kind of played a role. But I guess to start with, again, who were the participants?
Sure. So for the first study, we recruited 366 young adults, 18 to 26 in Los Angeles, using kind of more traditional recruitment methods, going out on the streets, going to different neighborhoods, Hollywood, college campuses, beaches, and there was some kind of chain referral that happened as well. We had a quite diverse sample, kind of reflected the demographics in Los Angeles. Over 50% identified as Hispanic. About a third were women. A good chunk had some college. They weren't all college graduates, but they were probably more educated than most. And when we built out the study, it was focused on comparing medical cannabis patients to non-patient users, if you will. So the patients, most of them, their condition had to do with some kind of mental health problem. So it was depression, anxiety, not so much physical problems as much, but kind of more challenges young adults would have, and those were the rationale why they were getting the recommendation. So that was kind of built into some of them having those mental health, not necessarily at high DSM kind of levels, but generally that was kind of the background of them, where anxiety, depression was as well as the interestingly the non-patient users, or the non-patients, many of them also had high levels of anxiety and depression, but just never chose to get a recommendation for a variety of reasons. So that was one surprise to us, that sometimes the levels were almost comparable. Just one group was deciding to get the recommendation, the other group was not.
I'll stick with the cannabis half of the study for a moment. You had a slide early in that presentation that showed use steadily increasing as cannabis products have become legalized in many places, and at least some data that showed that problem use was also going up as a result of that. And it seems like we're at the very earliest stages of doing the same sort of thing with legalizing sports gambling online. And there's sort of a theory that we underestimate how much marketing and distribution systems can increase demand for gambling or cannabis, and that some portion of people are going to end up in trouble because of that. Right. So, like, how does the field think about the trade-off in that way?
Yeah. Well, it's interesting with our sample were all current users when we enrolled them.
Right.
And what we found is that over the course of the study, their use generally started to decline, even as access legalization occurred. And so there could be some of the, what's called maturing out, to just as
light course sort of stuff. Yeah.
But they weren't exiting or completely stopping. So that's kind of where the controlled use piece fits in. So you continue to use, but in a more lower level, in a more controlled manner. So that's kind of what we saw in our data. So there's this two groups, one that's kind of staying steady state, and another group, their use is going down, and they're applying maybe these different rules. That's kind of what we're trying to figure out. But I guess to your broader point, so it's basically once you make something more available, there's going to be some people on the sidelines who now decide to do it. So I think it is a trade-off, because certainly, I used to think about this before cannabis was legalized. The trade-off of having it criminalized is all of the negative effects in terms of people getting caught up in the net of prison and incarceration, and or tainted drug supply, people not knowing what they're getting. So I think there's there's maybe this. So we do need to figure out. It's not by no means not a. There's harms obviously with cannabis, especially these products as they become more potent and widely available. But I think we need to study both ends of the continuum: the ones who are having the problems, and then the ones who aren't, to kind of really understand, what are the ones who aren't having the problems? What are they doing right? How are they getting by and kind of keeping it together?
How much did you have your hand up?
Just quickly, and maybe I'll ask you later. I'm so glad Matt actually asked that question, because I'm not trying to put you on the spot here, but it's clear to me that in public health, because of the previous harms, especially when it comes to cannabis, we're very careful about how we speak about the trade-offs. I was wondering if there is a broader conversation about how, yes, it's more available and potent,
the way I'm thinking about the structure, and at least some of the reports I'm seeing, is in only a small percentage of people are being affected severely, but people are being affected
Sure.
severely. But because of what you just said about the trade-offs in the past, which I don't think anyone is disputing, we seem to be moving more in the direction of more let it be alcohol,
Mhm.
instead of thinking, can we go in the direction of smoking where we actually provide regulations?
Right.
And can we actually have a more nuanced conversation about what's happening with cannabis without saying we're disregarding the past?
Mhm. Yeah, absolutely. And, interestingly, with cannabis, a lot of this has come about through voter
Yeah.
initiation. So this is not coming straight out of policy recommendations. It's people saying, hey, it's time to legalize.
And governments realizing their taxes to be
Yeah.
Exactly.
by selling it, and to be candid.
Sure.
Yeah,
Yeah.
exactly.
That's
A
it.
lot of it. So, well, thank you very much. We have to get you to
All
your
right.
next spot, but
Thank you all.
that's great.